Now we are going to start ileostomy and colostomy. What is ileostomy? It is the exteriorization of ileum to the abdominal skin. And what is colostomy? This is exteriorization of colon to the abdominal skin. Now see the sites of ileostomy and colostomy. So here you can see what is the ideal site of ileostomy. In this image you can see it is in the right iliac fossa. So ileostomy, ideal location, it is right iliac fossa. And if you see sigmoid colostomy, the ideal location is left iliac fossa. What about transverse colostomy? So transverse colostomy is done in right upper quadrant. Most of the questions which are asked in relation to stoma, ileostomy and colostomy, so those questions are related to complications. So see the complications, stomal complications are divided into early complications and late complications. Early complications are seen within 1 month and the late complications are seen after 1 month. So here you can see it is seen within 1 month. And what are the complications? Retraction, there can be abscess, there can be poor location. Poor location means whenever location is close to some bony prominence where it is very difficult for you to fit the stoma bag. Ischemia or necrosis. Why there is ischemia or necrosis? Sometimes the opening in abdominal wall is very tight. So whenever bowel is coming out, what happens? There is obstruction and there is impaired vascular supply. Sometimes you perform extensive dissection. So what happens? The vascularity of bowel is compromised and it will lead to what? Ischemia or necrosis. Sometimes there is detachment. Dermatitis occurs because of effluent. If the liquid effluent is there and there is spillage of effluent, it causes dermatitis. There can be opening of wrong end and output when the output is high. Output, it's high. Especially high output is seen in ileostomy. So how to remember early complications? There is mnemonic and the mnemonic is rapid O. This is rapid O. So what is this rapid O? You can see here retraction, abscess, poor location, ischemia and necrosis, detachment, dermatitis, opening wrong end and output high. Now see the late complications are seen after 1 month and the late complications are they can be stenosis, they can be prolapse. When there is prolapse, whenever the opening in the abdominal wall is large. So especially prolapse is common in colostomy. Parastomal hernia, whenever we perform extensive dissection around the opening, so especially it is common in end colostomy. There can be fistula, gas, order obstruction. So how to remember late complications? Here the mnemonic is SPF GO. SPF GO means stenosis, prolapse, parastomal hernia, fistula, gas, order obstruction. So rapid O, SPF GO, these are the complications you have to remember, early and late complications. Now one by one we are going to discuss. First we are going to discuss complications of ileostomy and then complications of colostomy. Now see what is the most common early complication of ileostomy. So whenever we create ileostomy, we have to observe the color of ileostomy and it should be pink. Here you can see what within very short duration what happens, it becomes dusky and after that it becomes black. So what happens? There is ischemia or necrosis. So most common early complication of ileostomy, most common early complication of ileostomy is very important, ischemia or necrosis. This is ischemia or necrosis. Clear? And if we see overall what is the most common complication of ileostomy, so you know that from ileum the liquid effluent is there. So there is spillage of this liquid effluent. So it is going to cause irritation. So this is what dermatitis. So overall, what is the most common complication of ileostomy? This is dermatitis or there is skin excoriation. There is dermatitis or there is skin excoriation. Now see these images. What is parastomal hernia and what is prolapse? Here you can see herniation by the side of stoma. You can see here there is herniation of bowel by the side of stoma. So this is known as what? Parastomal hernia. And obviously parastomal hernia will be seen in the patients where extensive dissection has been performed around the opening in abdominal wall. So if we see most common complication of both end colostomy as well as loop colostomy, most common complication, that is parastomal hernia. This is parastomal hernia. Clear? Now see, this is the prolapse. In this image you can see what? There is prolapse of colon. So prolapse is more common when the opening is larger, and obviously in the loop colostomy the opening will be larger. So prolapse, it is more common in obviously loop colostomy. Prolapse, it is more common in loop colostomy. So here this is prolapse which is more common in loop colostomy. Parastomal hernia we discuss in end colostomy. We perform extensive dissection. That's why parastomal hernia, it is more common in end colostomy. It is more common in end colostomy. So overall, most common complication of both end colostomy as well as loop colostomy, parastomal hernia. Prolapse more common in loop colostomy, and parastomal hernia, it is more common in end colostomy because we perform extensive dissection in end colostomy. So this is all about ileostomy and colostomy. Now we're going to discuss inflammatory bowel disease, and majority of questions in inflammatory bowel disease are asked in relation to differences between Crohn's disease and ulcerative colitis. So in detail, we are going to discuss the differences. First, see the macroscopic features of Crohn's disease and ulcerative colitis. You know that in Crohn's disease, any part of GIT can be involved. From mouth to anus, any part can be involved, but there are skip lesions. So what? It is segmental. It's a segmental disease with skip lesions, or there are skip areas. But what happens in ulcerative colitis? First, there is involvement of rectum, and then the lesion move cranially upwards. So there is involvement of rectum, then sigmoid, then descending colon, and then transverse colon. So here there are continuous areas, continuous lesions without any skip areas. Now location. What is the most common part of GIT involved in Crohn's disease? There is involvement of ileum plus cecum. Sometimes there is involvement of ascending colon. So most commonly ileum and cecum involvement. After that, there can be involvement of ascending colon. And in ulcerative colitis, disease starts from rectum, then it is going to involve sigmoid, and it moves cranially upwards. Extent, you know that in Crohn's disease, all the three layers of bowel are involved. Means full thickness of bowel is involved. So this is transmural. It is transmural. But what happens in ulcerative colitis? Microscopically, there is involvement of only mucosa and submucosa, microscopically. But macroscopically, it is superficial, and what? It is confined to mucosal layer. But microscopically, there is involvement of mucosa plus submucosa. If you see the ulcer, what kind of ulcers are seen in Crohn's disease? There are serpiginous ulcer, and it can progress to deep ulcers. Whereas in ulcerative colitis, there are superficial mucosal ulcers. You know, pseudopolyps, these are more common in which one? Crohn's disease or ulcerative colitis. So you know that pseudopolyps are more common in ulcerative colitis. Fibrosis and stricture. Fibrosis and stricture, this is more common in Crohn's disease. So fibrosis and stricture, it is more common in Crohn's disease. Since there is extensive fibrosis in Crohn's, what happens? There is shortening. So because of fibrosis, there is shortening. In cases of ulcerative colitis also, shortening occurs, but here shortening is not due to fibrosis, it is because of contraction of muscularis. So in ulcerative colitis, the shortening occurs because of contraction of muscularis. So these are the macroscopic features. Now see microscopic features. Now see the microscopic features of Crohn's disease and ulcerative colitis. So we already discussed that depth of inflammation in Crohn's disease, it is transmural, means there is involvement of what? Mucosa plus submucosa plus muscularis propria, and in ulcerative colitis there is involvement of only mucosa and submucosa. Second, type of inflammation. So in Crohn's disease there is non-caseating granuloma, presence of non-caseating granuloma, and there are mononuclear cells infiltrate. Whereas in ulcerative colitis there is non-specific acute and chronic inflammatory cells, presence of non-specific. So there is non-specific acute and chronic inflammatory cells in ulcerative colitis. Mucosal changes. So what happens in Crohn's disease? There are patchy ulcerations. And if we see the mucosal changes in ulcerative colitis, there is hemorrhagic mucosa with ulceration. In Crohn's disease, the submucosa is widened. What is the cause of widening of submucosa? Widening of submucosa, it is because of edema and presence of lymphoid aggregates. But in ulcerative colitis, the submucosa is either normal or it is reduced. Either normal or it is reduced in the width. If you see muscularis in Crohn's disease, it is infiltrated by inflammatory cells. But we discussed that in ulcerative colitis, muscularis propria, that is spared. And we discussed two important findings. Fibrosis, stricture, these are more common in Crohn's disease. So fibrosis is present, but in ulcerative colitis, fibrosis is absent. Now see the complications in Crohn's disease and in ulcerative colitis. So another important point, fistula. Fistula, whether it is internal or external, this is more common in Crohn's disease. Perineal involvement, that is more common in Crohn's disease. But fistula, it's rare in ulcerative colitis. So you can see here, both external as well as internal fistula. It is common in Crohn's disease. So it is seen in what percentage of patients? Seen in 10% of patients. But fistula, it is rare in ulcerative colitis. Now, malignant change. If you see the colon cancer, risk of malignancy, risk of colon cancer, it is equally common in ulcerative colitis as well as Crohn's disease. But small intestinal malignancy, this is more common in Crohn's disease. So small intestinal malignancy, this is more common in Crohn's disease. And you know that for cholangiocarcinoma, ulcerative colitis is a risk factor. So here, risk of cholangiocarcinoma is more in ulcerative colitis as compared to Crohn's. So here, it is more in ulcerative colitis as compared to Crohn's. Now coming back, fistula, strictures, fibrosis, all these are more common in Crohn's. So here, fibrotic strictures, these are common. Fibrotic strictures are common, but in ulcerative colitis, fibrotic strictures, these are rare. And you know, toxic megacolon is more common in ulcerative colitis. So toxic megacolon, it is common in ulcerative colitis, but toxic megacolon, it is rare in Crohn's disease. Rare in Crohn's disease. There are certain named signs which are asked frequently in relation to Crohn's and ulcerative colitis. So first see the named signs of Crohn's disease. So there is string sign of Cantor. Why? Because there is long stricture of terminal ileum. There is hose pipe appearance. So string sign of Cantor, hose pipe appearance. There is creeping fat sign, which is characteristic feature of Crohn's disease. Cobblestone appearance, because in between there is normal mucosa and then there are involved area. So this is cobblestone appearance. Comb sign, there is vascular jejunization of ileum, that is comb sign. Raspberry thorn or rose thorn appearance. There are linear transmural ulcers or fissure. This leads to raspberry thorn or rose thorn appearance. And fat halo sign, what is this? There is presence of low submucosal, low attenuation submucosal fat around the bowel. So low attenuation of submucosal fat around the bowel, that is fat halo sign. So how to remember? The mnemonic is string has CRF. How to remember here? For Crohn's disease, the mnemonic is string has CRF. So string, sign of Cantor. H means hose pipe appearance. C means creeping fat sign. Cobblestone, comb sign. R means raspberry thorn or rose thorn appearance. And F, that is fat halo sign. So string has CRF. What are the named features of ulcerative colitis? You know that in ulcerative colitis, especially in chronic cases, there is ahostral colon. And that ahostral colon, it is also known as lead pipe sign. Other name is pipe stem colon. Other name is garden hose appearance, and other name is stovepipe appearance. So all these are the names for ahostral colon. Lead pipe sign, pipe stem colon, garden hose appearance, and stovepipe appearance. And in ulcerative colitis, there are collar button ulcers. These are actually deep ulcers. So how to remember? LPG, stove, collar button. Mnemonic is LPG, stove. This is LPG, stove, collar button. So this is LPG, stove, collar button. Clear? So lead pipe sign, pipe stem colon, garden hose appearance, stovepipe appearance, and collar button ulcer. These are seen in ulcerative colitis. So these were the important points related to inflammatory bowel disease. Now we're going to start appendix. First, what is the normal length of appendix? Normal length, it is 2 to 20 centimeter. And what is the intraluminal capacity? Intraluminal capacity, that is 0.1 ml. Now see the blood supply. Here you can see what is the name of this artery. This is ileocolic artery. And this is appendicular artery. So appendicular artery, it's a branch of ileocolic artery and it's an end artery. So this appendicular artery, it is supplying the appendix. So blood supply of appendix, it is from appendicular artery. This is from appendicular artery. And you know, this appendicular artery, it's an end artery and it is a branch of, ileocolic artery. Ileocolic artery. Now the questions are asked in relation to the position of appendix. So what is the most common location? The most common location, it is behind cecum, that is retrocecal. So the most common location of appendix, that is retrocecal. What is the least common location? You can see it is post-ileal. So post-ileal, this is least common. After that, most dangerous location, it is pelvic. So pelvic, this is most dangerous location. This is most dangerous location. After that, nowadays image-based questions are asked. This question was asked in latest INI-CET. This image-based question was asked and they asked the position. So here you can see A, this is retrocecal. C, this is in front of ileum. So you can see here, this is pre-ileal. And B, this is behind ileum. So this is post-ileal. Post-ileal. D, you can see this is pelvic. E, E is subcecal. E, this is subcecal. Subcecal. And here you can see this is paracecal. So you should be ready for this kind of image-based question. Clear? This was asked in INI-CET. So I'm repeating. Most common location, retrocecal. Least common location, post-ileal. Most dangerous location, that is pelvic. Acute appendicitis, this is the most common general surgical emergency worldwide. It is seen in young patients, especially in second decade. And what is the cause? It is caused by luminal obstruction. It is caused by luminal obstruction. And in majority of cases, it is caused by luminal obstruction. It is caused by fecolith. So in appendiceal lumen, the obstruction, it is caused by fecolith. Clear? Now you know that appendix develops from midgut. So whenever there is obstruction, what happens? From midgut, patient is going to perceive pain in periumbilical region. So initially in acute appendicitis, there is pain around periumbilical region. But what happens after 4 to 6 hours, pain migrates to right iliac fossa. Why? Because of acute appendicitis, there is collection of fluid. This fluid irritates the pain sensitive parietal peritoneum. So what happens? There is pain which is migratory. After that, patient is also having anorexia, there is nausea, vomiting. So there is one score by which we can diagnose the appendicitis. Name of score is Mantel score or Alvarado score. So see the clinical features. Patient is having migratory pain, anorexia, nausea, vomiting. Migratory pain, this is the most characteristic symptom. This is most characteristic symptom. Most characteristic symptom. Clear? Now see the signs. Patient is having tenderness. There is rebound tenderness. There is elevated temperature. Tenderness, rebound tenderness, elevated temperature. And if you perform the laboratory diagnosis or in laboratory investigations, there is leukocytosis and shift to left. So what is the name? This is known as Mantel score, also known as Alvarado score. So name of this score, it is Mantel's. This is known as Mantel score, also known as Alvarado score. Alvarado score. Clear? How many components are there? Total 8 components are there. Out of 8 components, 6 components are having score of 1. Only 2 components are having score of 2. So which 2 components are having score of 2? How to remember? LT2, full form, lecture theatre second floor. LT2. So L, leukocytosis, and T, tenderness. These are having score of 2. Rest all are having score of 1. So how much is the maximum score? Maximum score is 10. See the interpretation. So if the score is 9 to 10, it means diagnosis is certain. Diagnosis is certain. If the score is 7 to 8, it means there is high likelihood of diagnosis. High likelihood of diagnosis. If score is 5 to 6, it means it is equivocal. This is equivocal. And if it is 1 to 4, it's negative. It's negative. So out of these, which one is most dangerous situation? The most dangerous situation is when the score is 5 to 6. It means it is equivocal. So you have to confirm the findings. So whenever the score is 5 to 6, the diagnosis should be confirmed by CCT. When it is equivocal, score is 5 to 6, diagnosis should be confirmed by CCT. Now see 2 important questions. First, what is the most characteristic symptom? That is migratory pain. And what is the most characteristic sign? That is Rousing sign. So what are the important signs in relation to acute appendicitis? Have a look. Now imagine this is the patient. Okay. And if I'm pressing left iliac fossa, on pressing left iliac fossa, there is pain in right iliac fossa. This is known as Rousing sign, and this is most characteristic sign of acute appendicitis. Now imagine if a patient is having pelvic appendicitis, the orientation of appendix is towards pelvis. So in that case, there is pain on internal rotation of right thigh over hip joint. This is known as obturator sign. So in obturator sign, what's the problem? There is pain on internal rotation of right thigh over hip joint, and it is positive in pelvic appendicitis. Positive in pelvic appendicitis. Now, another situation, imagine patient is having retrocecal appendicitis. Here is the appendix, so it is behind cecum. This is retrocecal. So, in retrocecal appendicitis, what's the problem? There is, if patient is going to perform hyperextension at right hip joint, it leads to pain. So, hyperextension at right hip joint leads to pain, and it is positive in retrocecal appendicitis. So, these are the signs which are frequently asked. Most characteristic sign, that is Rovsing sign. So what is the name of this sign? This is SOS sign. Hyperextension at right hip joint leads to pain in right iliac fossa. It is positive in retrocecal appendicitis. Now see the diagnosis of acute appendicitis. Diagnosis, it is clinical, but it is supplemented by ultrasound and laboratory investigation. So which finding is there on laboratory investigation? Leukocytosis. So diagnosis of appendicitis, it is clinical. It is clinical. It is supplemented by ultrasound and laboratory investigation. And which finding on laboratory investigation? There is leukocytosis, right? But what is the problem in children? Obviously, they will not give the detailed history. So, what is the investigation of choice for diagnosis of acute appendicitis in children? It is ultrasound. Investigation of choice for diagnosis of acute appendicitis in children, ultrasound. And what is the gold standard investigation for acute appendicitis? It is CCT. The gold standard means we can confirm the diagnosis or we can rule out the diagnosis by CCT. So gold standard investigation, that is CCT. And you know what is the treatment when the diagnosis is established? Obviously the treatment is emergency appendectomy. So treatment of acute appendicitis, that is emergency appendectomy. We perform emergency appendectomy. Okay. Whenever we take patient for emergency appendectomy, after anesthesia, we are going to palpate the abdomen again. And if on palpation you are going to find a lump, that is appendicular lump, in that case we have to abort the surgery, because if there is a lump, we will manage this patient by a regime that is known as Ochsner-Sherrin regime. Ochsner-Sherrin regime, it's a conservative management of appendicular lump. You have to confirm the diagnosis. So we have to perform CCT to confirm the diagnosis, and we have to give IV antibiotics. So start IV antibiotics and we perform CCT for confirmation of diagnosis. And apart from this, we have to go for vitals monitoring. So we perform or we go for vitals monitoring. So what we monitor here, we monitor pulse and temperature. So vitals monitoring, we monitor pulse rate and temperature every 4 hourly. Every 4 hourly. What happens? Most of the patients are going to improve after conservative management, and in that case we have to perform interval appendectomy. So if patient improves after 4 to 6 weeks, we go for interval appendectomy. Interval appendectomy, and it is done after 4 to 6 weeks. Clear? For interval appendectomy, patient should be having recurrent appendicitis. Recurrent appendicitis means after this episode, there should be another episode in which patient felt the pain. There should be another episode of pain. That is recurrent appendicitis. But in certain situation, what happens? Patient is going to deteriorate. Why? Because appendicular perforation is going to occur. So what are the indications of exploratory laparotomy? So how to remember? Mnemonic is PSM. P means pulse rate, it is rising. S means spreading abdominal pain. Why? Because patient developed peritonitis. M, mass size increasing. So in these cases, these points are or these symptoms are suggestive of appendicular perforation. So these findings are suggestive of appendicular perforation. And if there is appendicular perforation, we have to open the abdomen by midline incision. So this is the indication for exploratory laparotomy. So indications for exploratory laparotomy: pulse rate rising, spreading abdominal pain, mass size increasing. What are the factors which are going to increase the risk of appendicular perforation? So how to remember? There is a mnemonic. What? Ficholith. Mnemonic is Ficholith dye in pelvic surgery. Mnemonic is Ficholith dye in pelvic surgery. Pelvic surgery. Clear? So fecalith means first fecalith obstruction. D means diabetes mellitus. I means immunocompromised state. E means extremes of ages. Extremes of ages means if the patient age is less than 5 years or patient's age is more than 65 years. So less than 5 years or more than 65 years. Pelvic means pelvic appendicitis, and surgery if there is history of previous surgery. So these are the risk factors for appendicular perforation. Now see the carcinoid tumor of appendix. This is the most common tumor of appendix arising from Argenta-Finn cells. That's why what is the other name? Argenta-Phenoma. Usually carcinoid tumor in appendix, it is small, it is localized, and what is the most common site in appendix? It is located at the tip. Small, localized, most common site in appendix, it is tip. And it is not associated with carcinoid syndrome, not associated with metastasis. Clear? Most common site in appendix, it is tip. Now, you know that in carcinoid tumors, the risk of malignancy increases with size. So, if the size of tumor is up to 1 centimeter, what is sufficient? We go for appendectomy. And whenever size is more than 2 centimeter, we go for right hemicolectomy. So, size up to 1 centimeter, what is sufficient here? We go for appendectomy. Appendectomy. And whenever size is more than 2 centimeter, here we go for right hemicolectomy. Right hemicolectomy. Whenever the size is more than 1 to 2 centimeter, here in majority of cases we go for appendectomy. So in this situation, in majority of cases we go for appendectomy, but in some cases we go for right hemicolectomy also. See the indications. So whenever size is more than 1 to 2 centimeter, but in such patients there is involvement of mesoappendix, if there is involvement of cecal base or involvement of lymph node, in these cases we have to go for right hemicolectomy. So this is the question which is asked frequently, that the size of carcinoid tumor of appendix, it is more than 1 to 2 centimeter. What are the indications of right hemicolectomy? If there is involvement of mesoappendix, involvement of cecal base, or there is involvement of lymph node. So in all these cases, we perform right hemicolectomy. Suppose this is the patient, this is umbilicus, this is anterior superior iliac spine. So you join it. This is spino-umbilical line. In the spino-umbilical line, at the junction of lateral 1/3 and medial 2/3, there is a point, and this point is known as McBurney's point. So what is the name of this point? McBurney's point, and you know, this is the most tender point. What's the name of this point? This is McBurney's point. McBurney's point. This is the most tender point in acute appendicitis, and it corresponds to base of appendix. It corresponds to base of appendix. Clear? So there is one incision which is known as McBurney's incision, also known as MacArthur incision, also known as gridiron incision. McBurney's, MacArthur, gridiron incision. So what we do in this case? In this case, we give incision centered at McBurney's point, perpendicular to spino-umbilical line. This is a muscle splitting incision. Centered at McBurney's point, perpendicular to spino-umbilical line. Muscle splitting incision. Some patients who are having retrocecal appendicitis, it's very difficult to visualize the appendix. So in that case, what we can do, we can extend this incision upward and laterally. How you extend this incision? By cutting the conjoint tendon. Means internal oblique and transversus abdominis, we have to cut these muscles. This is known as Rutherford-Morrison incision. So Rutherford-Morrison incision is muscle cutting incision, and you know McBurney's incision, this is muscle splitting incision. So what happens in Rutherford-Morrison incision? McBurney's incision, it is extended upward and laterally by cutting conjoint tendon. Which muscles? Obviously internal oblique and transversus abdominis. Clear? So since you are cutting the muscle, this is cutting incision, and for which appendicitis we are using this Rutherford-Morrison incision, especially for retrocecal appendicitis. There is the third incision that is known as Lange incision. Now you can see what is that Lange incision. You can see this is the midpoint of clavicle and this is midpoint of inguinal ligament. You are going to join it with a line. Now you can see this is umbilicus. So 2 centimeter below umbilicus. We give a transverse incision. 2 centimeter below umbilicus, transverse incision. On this line, this is known as Lange incision. Lange incision, and this is along skin crease. Clear? So that's why it is cosmetically better. Other names of Lange incision, it is known as modified McBurney's incision, also known as Rocky Davis incision, because of better cosmetic appearance, also known as bikini incision. Why? Because of better cosmetic appearance. So because of better cosmetic appearance, this is also known as bikini incision, and again it is muscle splitting incision. So where we give you this incision on the line joining midpoint of clavicle to midpoint of inguinal ligament, 2 centimeter below umbilicus, and what kind of incision? It's the transverse incision. What is the most common complication of appendectomy? That is wound infection. You might have seen these patients in the ward. Apart from wound infection, it can cause intra-abdominal abscess also. There can be ileus also. It can lead to venous thrombosis, portal pyemia. There can be adhesive intestinal obstruction. And this is important. Why? Because this is most common late complication. What is the most common late complication of appendectomy? So the most common late complication of appendectomy, that is adhesive intestinal obstruction, and it can cause fecal fistula also. What happens in fecal fistula? Whenever we are going to injure the base of cecum, or sometimes from the appendicular stump there is leakage. So these are the complications. Most common wound infection, and most common late complication, that is adhesive intestinal obstruction. So this is all about appendix. Now we are going to start rectum and anal canal. First of all, we are going to discuss hemorrhoids. Hemorrhoids are normal anatomical cushions which helps in defecation. And what is the location? You can see it is located at 3 o'clock, 7 o'clock and 11 o'clock position. So 3 o'clock, 7 o'clock and 11 o'clock position. Now what is the problem in these patients? These patients have constipation, and because of constipation these patients are going to strain. So what will happen? There is abnormal descent. Because of excessive straining, there is abnormal descent, and because of this abnormal descent, there is injury by hard fecal matter. And if there is injury by hard fecal matter, since patient is having constipation, so there is injury by hard fecal matter, and because of that, patient is having what? Bleeding. And usually, what kind of bleeding? It leads to painless bleeding. So in hemorrhoids, there is painless bleeding. Painless bleeding. We already discussed that what is the most common cause of lower GI bleed? The most common cause of lower GI bleed, that is hemorrhoids. How much bleeding is occurring? 1 ml, 2 ml, 3 ml, 5 ml. Means small amount of bleeding is there. Second, most common cause of significant lower GI bleeding, that is colonic diverticula. And what is the most common cause of occult means hidden, most common cause of occult lower GI bleeding, that is angiodysplasia. What is the presentation here? These patients usually present with painless bleeding. Sometimes there is mucus discharge and prolapse. How we are going to investigate? So whenever patient is coming, we perform digital rectal examination. But let me tell you, hemorrhoids are non-palpable. So if we perform digital rectal examination, hemorrhoids are non-palpable. These are non-palpable. So how we make the diagnosis? Investigation of choice for diagnosis, that is proctoscopy. So hemorrhoids are non-palpable. That's why investigation of choice for diagnosis, this is proctoscopy. So in hemorrhoids, it is what? Proctoscopy. Now, there are two types of hemorrhoids. One is internal hemorrhoid, one is external hemorrhoid. It's very easy to understand. See, this is the anal canal. In the anal canal, you can see this is the dentate line. Dentate line. So what happens? Internal hemorrhoid, it is located internal to dentate line. This is internal hemorrhoid. And external hemorrhoid, it is located external to dentate line. So this is what? Internal, and this is external. Clear? You know that this internal hemorrhoid, it is located internal to dentate line, that is pain insensitive region. That's why there is painless bleeding. And external hemorrhoid, it is located in pain sensitive region. That's why there is painful bleeding. So internal hemorrhoid located internal to dentate line, there is painless bleeding. And what is the treatment? Treatment depends on the degree. So treatment of internal hemorrhoid depends on the degree, which we are going to discuss very soon. And external hemorrhoid, it is located external to dentate line. That's why there is painful bleeding, because it is located in pain sensitive region. It is also known as 5 days painful self-curing lesion. Other name is 5 days painful self-curing lesion. Why? Because whenever there is thrombosis, what happens? If patient is going to take some painkillers, what happens? Or if patient is not seeking any treatment, pain disappears after 5 days. So that's why there is 5 days painful self-curing lesion. If recurrent thrombosis occurs in hemorrhoid, the appearance is like semi-ripe black currant. So because of recurrent thrombosis, what kind of appearance is there? There is semi-ripe black currant appearance. Semi-ripe black currant appearance. And in external hemorrhoid, what is the treatment? The treatment is excision. So for external hemorrhoid, treatment is excision. Clear? We discussed that the treatment of internal hemorrhoid, it is dependent on the classification. So have a look of classification of internal hemorrhoid. In the first degree, there is bleeding only. So in the first degree, there is only bleeding. In the second degree, there is bleeding plus prolapse during defecation, and after defecation, the prolapsed part goes inside. So second degree, there is bleeding, bleeding plus prolapse during defecation. There is prolapse during defecation. During defecation. In third degree, there is bleeding plus prolapse. With fingers, patient is going to put that prolapse inside. So what here? Here there is bleeding plus prolapse with manual reposition. Bleeding plus prolapse with manual reposition. Go for manual reposition. And what happens in fourth degree? There is bleeding plus permanent prolapse. Bleeding plus permanent prolapse. Permanent prolapse. Okay. The management depends on the degree. So whenever a patient is having first degree of hemorrhoid, we just advise conservative management. Means what? We have to treat the constipation. So stool softeners, high fiber diet. So for first degree, sitz bath, high fiber diet and stool softeners. Majority of patients are going to improve. If patient is not going to improve in first degree, in second degree and selected patients of third degree, we have two options. One is rubber band ligation and the second is sclerotherapy. So in this image, you can see this is internal hemorrhoid, and around this internal hemorrhoid, we are going to apply the rubber bands. So this is rubber band ligation. What will happen? After this application, there is ischemia at the pedicle, and within 48 hours, it will be sloughed off, and healing occurs with fibrosis. What we do in sclerotherapy, here we inject 5% phenol. In sclerotherapy, we inject 5% phenol in almond oil. In almond oil. So 5% phenol injected in almond oil here. So what will happen? Whenever this substance is injected, there is sclerosis. After that, what will happen? Fibrosis. These techniques are cheap, safe and highly effective. And these are used for first degree, second degree and selected patients of third degree. So we have two options, rubber band ligation and sclerotherapy. Now see another problem. Some patients of third degree and fourth degree, what happens? There is prolapse of hemorrhoid. Since there is prolapse of hemorrhoid, so in such patients we have to excise this, and this is known as hemorrhoidectomy. So for rest of third degree and fourth degree patient, we go for hemorrhoidectomy. First is Milligan-Morgan open hemorrhoidectomy, and the second is Longo-Stapler hemorrhoidectomy. Which one is preferred? It's the Longo-Stapler hemorrhoidectomy. It is preferred. Why? Because there is lesser pain. There is lesser pain. So another question, what is the most common complication of hemorrhoidectomy? And the most common complication, that is pain. Most common complication of hemorrhoidectomy. And most common complication of hemorrhoidectomy, that is pain. And this pain is responsible for urinary retention. So it is pain followed by urinary retention. Whenever this question comes in exam, in majority of cases, pain option is not there. And if pain option is not there, what you have to mark? Urinary retention. So most common complication of hemorrhoidectomy, pain followed by urinary retention. Which one is preferred? We prefer Longo-Stapler hemorrhoidectomy. Next is rectal prolapse. In adults, rectal prolapse, it is full thickness. In adults, it is full thickness. And in children, it is mucosal. In adults, full thickness. In children, it is mucosal. Okay. Now see what's the difference. In full thickness rectal prolapse, you can see here, all three layers are coming out. And in mucosal prolapse, you can see here, there is only prolapse of mucosa. So one by one, we are going to discuss. First, we are going to discuss rectal prolapse in children. Now see the causes of rectal prolapse in children. Most of the patients are suffering from protein energy malnutrition. Because of that, they have habit of pica, and because of pica, they have worm infestation, and because of infections, they have diarrhea. So all these are related. And what is the easy treatment? What you just treat the underlying cause, patient will improve. So in all these cases, what is done? Nothing. Just treat the underlying cause. So treatment of underlying cause. And if you treat the underlying cause, most patients are going to improve. Treatment of underlying cause. Imagine even after treatment of underlying cause, there is no improvement. In these cases, we go for rectopexy. And what is the name of that rectopexy? Here we go for Lockhart-Mummery rectopexy. So what's the name? Name of this rectopexy. This is Lockhart. This is Lockhart-Mummery rectopexy. So the name is Lockhart-Mummery rectopexy. Clear? Now, if a patient is having sacral agenesis, patients who are having meningomyelocele, these patients are having poor prognosis. In such cases, what we are going to do, we are going to perform Thiersch anal wiring. So in Thiersch anal wiring, what's done? Suppose this is the rectum, this is the anal canal. Rectum is coming out, clear? Here. So what you do, you perform the anal encirclement. So if you perform anal encirclement, now it will not come out. So for sacral agenesis and meningomyelocele, we perform Thiersch anal wiring. So here we are going to perform what? Thiersch anal wiring, and it's a type of anal encirclement. So in this image, you can see how we perform it. We are going to pass a silastic tape, suture or nylon around this anal canal, and after that you can see here what I'm going to tighten it. I'm going to perform the suturing here. So this is anal encirclement. Here a tape is being used, and you can see here a suture is being used. So you apply the suture and then you ligate it. So this is anal encirclement operation, also known as Thiersch anal wiring, also known as Thiersch procedure. In adults, we discussed that there is full thickness rectal prolapse. We have two types of rectopexy. One is abdominal and the second is perineal. What is done in abdominal rectopexy here? In abdominal rectopexy, there is high morbidity, but risk of recurrence is low. In perineal rectopexy, the morbidity is low, but the risk of recurrence is high. So which one is preferred in young patients? Abdominal. And which one is preferred in elderly or frail patient? It is perineal. So you can see here, there is decreased recurrence rate but increased morbidity. That's why it is preferred in young patients. And in second, perineal rectopexy, there is increased recurrence but morbidity is low. That's why it is preferred in elderly or frail patient. These questions are frequently asked. And nowadays, from 2 to 3 years, repeatedly there is one question of rectal prolapse. They ask about the names of procedures, that which procedure is abdominal and which procedure is perineal. Now, how to remember? For abdominal rectopexy, mnemonic is VAR. Mnemonic is VAR. VAR means Wells, A means abdominal, R means Ripstein. So, Wells, abdominal, Ripstein. Wells and Ripstein, these are abdominal. And how to remember perineal? The mnemonic is PAD. PAD. So, here, P means perineal, Altmeus and Delorme. So, perineal approaches of perineal rectopexy are Altmeus and Delorme. And one you already know, Thiersch anal wiring. Obviously, it is a type of perineal rectopexy. So, Thiersch anal wiring, you already know that Thiersch anal wiring or Thiersch procedure, this is a type of perineal rectopexy. So, these names are frequently asked nowadays. Now, see anorectal abscess. You can see here, this is the anal crypt and this is the gland. So, this is the crypt and this is the gland. This is the dentate line. It is having opening here. This is known as crypt of Moragagni. The opening is known as crypt of Moragagni. So what happens? Sometimes infection reaches the anal gland. So whenever infection reaches the anal gland and there is formation of pus, this leads to anorectal abscess. So which kind of theory is responsible for anorectal abscess? This is known as cryptoglandular theory. What is the name of this theory? This is cryptoglandular theory. So cryptoglandular theory, this is responsible for anorectal abscess. Second, what is the most common organism responsible? And the most common organism responsible? It is E. coli followed by bacteroids. This is E. coli followed by bacteroids. So what will happen? Pus find its track and it is follow the path of least resistance. So it is collected around anus. That's why the most common type of anorectal abscess, it is perianal followed by ischiorectal. So the types are perianal. This is most common type. Second most common type, that is ischiorectal. It is second most common type. Third is submucous and fourth is pelvirectal. Now see the patient. This patient is having pus collection here. So what happens here? The pus is under 10 septa. What happens? These patients are having severe pain whenever they develop anorectal abscess. Apart from that, what kind of swelling? There is throbbing swelling and the patient is having swinging pyrexia. So severe pain, throbbing swelling, swinging pyrexia. In this case, what we have to go for? Obviously, we have to go for incision and drainage. So in such patients, we go for incision and drainage. And what kind of incision we have to give? Crisscross incision. So this is known as what? Cruciate shaped incision. Why? Because the central part of skin is excised. So in this image, you can see how this cruciate shaped incision looks like. So what is the treatment? Treatment is incision and drainage plus antibiotics. It is incision and drainage plus antibiotics. And what kind of incision? You can see here. We give cruciate shaped incision. We give cruciate shaped incision for anorectal abscess. So another problem which is related to anorectal abscess, what you can see here, this is the anal canal, this is the dentate line, and we discussed this was the anal gland, this was the crypt. So it was the cryptoglandular theory which was responsible for anorectal abscess. Now what happens? Imagine there is collection of pus. It was not drained. So what will happen? Pus will find its own track outside. And if it is going to rupture outside, what will be the problem? You can see here, there is formation of a fistula. So this is fistula, formation of a fistula known as fistula in ano. So obviously for fistula in ano also, which theory is responsible? Cryptoglandular theory. So for fistula in ano also, there is cryptoglandular theory. It's the cryptoglandular theory which is responsible. Clear? There are two types of fistula. One is simple and one is complex. Simple means single straight track, and complex fistula, it means it is having multiple branch track. You know, there is anorectal ring. So if fistula is having internal opening, this is the internal opening. So whenever this internal opening, it is located above anorectal ring, that is known as high-lying fistula. Whenever internal opening, it is located below anorectal ring, that is known as low lying. So high lying located above internal opening, located above anorectal ring, low lying located below anorectal ring. Now see the presentation. These patients are having external opening in the perineal region. You can see here. Patients are having external opening in the perineal region. And what is the complaint? They tell that, sir, I'm having intermittent purulent discharge and sometimes I'm having pain. Sometimes patient is going to tell you that, sir, from this external opening, I pass feces and flatus. If patient tells that he passes feces and flatus from external opening, it means the internal opening, it is located in rectum. Whenever the internal opening, it is in rectum, then only patient gives this kind of history of passage of feces and flatus from external opening. Whenever there is obstruction of the tract or sometimes infection, it can also cause abscess. So whenever there is obstruction and infection, it leads to abscess. And if patient is having abscess, obviously we have to drain it, perform IND and give antibiotics. Now coming to the investigations. In the fistula tract, you inject the dye. So the first investigation, it is fistulogram. But investigation of choice for diagnosis, that is MRI. The first investigation in fistula in ano, that is fistulogram. But the investigation of choice for diagnosis, that is MRI. There is a classification system for fistula in ano known as Parkes classification. In this image, you can see type 1. Here you can see this is type 1, that is intersphincteric. Type 2, that is transsphincteric. Type 3, suprasphincteric. And type 4, you can see here, this is extrasphincteric. Which one is most common? Obviously type 1, which is intersphincteric. So according to Parkes classification, it is intersphincteric, transsphincteric, suprasphincteric and extrasphincteric. 1, 2, 3, 4. Which one is most common? It is intersphincteric. And how to remember? It's very easy to remember. Mnemonic is it's extra. You can see here, it's extra. So 1, 2, 3, 4. I means intersphincteric, T means transsphincteric, S means suprasphincteric, and 4, that is extrasphincteric. In patients of fistula in ano, you can visualize the external opening. For internal opening localization, we perform digital rectal examination. If it is difficult to localize the internal opening, which rule is used for localization of internal opening on the basis of location of external opening? The name of rule, that is Goodsall's rule. Goodsall's rule. So this rule is used for localization of internal opening on the basis of external opening. But since we have MRI, MRI tells you everything about the tract, about the exact location of internal opening and secondary tracts. So that's why it's not required, but it is asked frequently in exam. What are the treatment options we have? You can see here, this is fistula. So whenever we give incision over this fistula tract, that is known as fistulotomy. And if you excise the fistula tract, that is known as fistulectomy. What is the problem with fistulotomy and fistulectomy? That it is going to create a wound. That's why patient compliance is not good. Nowadays, what is the preferred treatment option? We use Seton, and Seton can be cutting Seton and it can be draining Seton. Cutting Seton and draining Seton. What is the use of cutting Seton? It is going to convert high-lying fistula into low-lying fistula. It converts high-lying fistula into low-lying fistula. And draining Seton, it is going to drain the pus, drain the infection. So it is used to control, it controls infection. Especially the patients who are HIV positive and in Crohn's disease patient. In which patients? Patients who are HIV positive and Crohn's disease patient, we use draining Seton. So here you can see in this image, we are using this Seton inserted into the fistula tract, taken out, and after that it is tightened. Every week, if you're going to tighten it, what happens? It will start cutting the tissue. So this is cutting Seton. And if you apply it loosely, suppose I'm applying this Seton loosely, it is draining the infection or pus collection. It is known as draining Seton. There is another treatment option known as WAFT. This is video assisted anal fistula treatment. Video assisted anal fistula treatment, where you are going to cauterize the tract. And next is glue. We inject the glue inside the tract. So these are the treatment options. Preferred option nowadays, it is Seton. For high-lying fistula, to convert it into low-lying, we use cutting Seton. And for infected fistula, we are using draining Seton. Seton is available in the market by the name Char Sutra. What's the name? Char Sutra. This is fissure in ano. What happens here? There is longitudinal split in the anoderm from anal verge till dentate line. What is extent? From anal verge till dentate line. So there is longitudinal split. You can see here. Longitudinal split in the anoderm. Anoderm means the mucosa lining anal canal. So longitudinal split in the anoderm. What is the extent? Extent from anal verge to dentate line. Anal verge to dentate line. And you can see what is the location. If it's a clock, it is located at which o'clock position? You can see 12, 3, 6, 9. So exactly it is located at 6 o'clock position. So what? It is located posteriorly in the midline. Location posteriorly in midline. And it is located at 6 o'clock position. 6 o'clock position. What is the problem in this case? Basic problem. There are two problems. One, these patients have constipation, and the second, there is spasm of internal anal sphincter. So you can see here, this is internal anal sphincter. Constipation means patient is trying to pass hard fecal matter. So whenever we go for defecation, we have two sphincters. One is internal, second is external. Internal sphincter, this is involuntary. External sphincter, it is voluntary. So when you go for defecation, you are going to relax your external sphincter. But if you are having fissure in what? Internal sphincter is not relaxed. So if you are straining badly, what will happen? Hard fecal matter will try to come out, but it is going to injure pain sensitive anal canal. So there is difficulty in defecation and there is painful defecation. So what's the problem here? Two basic problems. First, these patients have constipation. These patients have constipation and there is spasm. Patients have spasm of internal anal sphincter. Simple. So in the management, what do you have to treat? You have to treat the constipation. So we will give fiber diet. We will give stool softeners. Spasm of internal anal sphincter. So we will advise relaxation techniques. We will advise calcium channel blockers or nitrates for dilatation or for relaxation of internal anal sphincter. So this is the pathophysiology. Remember this because it will be useful in understanding the management. So here, because of spasm of internal anal sphincter as well as constipation, there is severe pain during defecation. There is injury of pain sensitive anal canal. So sometimes there is streaking of blood during defecation on hard fecal matter. Are you going to perform digital rectal examination or proctoscopy? Both are contraindicated. So digital rectal examination as well as proctoscopy, these are contraindicated. Why? Because patient is having spasm of internal anal sphincter. It's very, very painful. So both of these are contraindicated. What we have to do, you just examine the gluteal region. You find a longitudinal split, especially in the posterior midline. So see the management. So initially we are going to advise conservative management, relaxation technique like sitz bath, and to treat the constipation, we give high fiber diet and stool softeners. Now see the medical management. In medical management, we can advise the patient to apply 2% diltiazem gel. And you know that diltiazem gel, it's a calcium channel blocker and it leads to relaxation of sphincter, which is a smooth muscle. Or we can advise 0.2% nitroglycerin gel local application. We can inject Botox, botulinum toxin also. If you remember, we discussed similar situation in esophagus and what was that condition? Achalasia cardia. In achalasia cardia, where was the problem? Absence of LES relaxation. In, in Fisher Nano, there is spasm of internal anal sphincter means internal anal sphincter is not relaxing. Both of these are smooth muscles. That's why in both we can give calcium channel blockers. There we were giving orally, here locally. There we were giving nitrates, here also it is applied locally. There also we were injecting what? Botox. Here also we are injecting Botox. There also we were doing the dilatation, bougie or balloon dilatation. And here we perform manual dilatation, that is known as Lord's procedure. So Lord's procedure, that is manual dilatation, though it's obsolete now because of increased risk of complications. We can use anal advancement flap. And what was the treatment of choice in achalasia cardia? Laparoscopic Heller's cardiomyotomy, where you were dividing the circular muscle fibers. Here also we are cutting the sphincter laterally. So what's the name? Notaras. Name is Notaras lateral sphincterotomy. So if you see, pathophysiology of achalasia cardia and Fisher Nano are similar. That's why management is also similar. So I'm repeating what we give: 2% diltiazem gel, 0.2% nitroglycerin gel local application. We can go for Botox injection. Lord's procedure, that is manual dilatation, it is obsolete. We can use anal advancement flap, but the treatment of choice, it is Notaras lateral sphincterotomy. This is pilonidal sinus. You can see here, sinus means there is a single opening. So here you can see, this is the opening. Clear? This is the opening. And in this case, what happens? There is collection of dead hair in natal cleft overlying the coccyx. So here you can see there is collection of dead hair in the natal cleft overlying the coccyx. So this is pilonidal sinus. This is acquired condition and it is exclusively seen in hairy males. Acquired condition, hairy males, also known as Jeep's disease. Why? Because it is more common in army personnel, especially Jeep drivers of army. So collection of dead hair in natal cleft overlying the coccyx. Now see the problem here. This is the cavity. In this cavity, there is collection of dead hair. Something like this. So these are the dead hair which are collected here. Now what is the problem? These patients will be having discomfort. Sometimes there is serous or seropurulent discharge. Whenever its tract is obstructed, so it's infected. Because of obstruction and infection, it can lead to abscess. So sometimes there is abscess formation, and if there is abscess, in such cases we give antibiotics and we go for IND. So we perform IND and give antibiotics whenever there is abscess. But what is the treatment, actual treatment? Since there is a cyst which is containing dead hair and it is having an opening, so we have to excise the whole cyst along with its tract. So this whole cyst is excised, and whatever the defect is there, this defect is closed with a flap. To the clinical features, these patients are having discomfort. Apart from discomfort, some of the patients are having intermittent serous discharge. There is intermittent serous discharge. We already discussed that there can be infection which can cause abscess. We have to perform IND plus antibiotics. The management of pilonidal sinus, it is excision of sinus tract and closure of defect with flap. Questions are asked that what are the names of flap which are used for pilonidal sinus. You have to remember flaps are Limburg's flap, Karidaki's flap, rhomboid flap. Limburg's flap, Karidaki's flap, rhomboid flap. These are the flaps used for closure of the defect. There is a procedure which is used in pilonidal sinus, and that is Bascom procedure. Bascom procedure. So in this Bascom procedure, what we are going to do, we are going to excise the tract and we are going to close the defect. So these are the names which are important. Limburg's flap, Karidaki's flap, rhomboid flap. These are the flaps which are used, and the name of procedure, that is Bascom procedure, which is used for pilonidal sinus. Carcinoma rectum, it's very, very important. First question, see, what is the most common site of large bowel malignancy? And that is rectum followed by sigmoid. So the most common site, it is rectum. Rectum. You know that in GI malignancies having hematogenous spread, what is the most common site of metastasis? It is liver. And what is the chemotherapy regimen in carcinoma colon as well as carcinoma rectum? We discussed it is FOLFOX4. So name of the chemotherapy regimen which we use, name is FOLFOX4. So what is the full form? You can see here. Full form, FOL, that is folinic acid, also known as leucovorin, F, that is 5-fluorouracil, OX, that is oxaliplatin. What is the problem here? You can see this patient is having carcinoma in the rectum. So this is the rectum. Here is the malignancy. What happens from this malignancy? What is the most common symptom? Obviously bleeding PR. So most common symptom in carcinoma rectum, that is bleeding PR. This is bleeding PR. This malignancy is going to occupy the space in rectum, and whenever patient is sleeping, what happens? There is bloody discharge, there is mucus discharge. So there is bloody discharge and mucus discharge. So early in the morning, patient is having intense desire of defecation, and patient is running towards toilet just for passing stool. What is the name of the symptom? Early morning bloody diarrhea. And actually speaking, patient is not passing stool. What patient is passing? Mucus and blood. So actually, patient is passing mucus and blood. So this is known as what? Passage of bloody slime. Since malignancy is occupying significant space in the rectum, so what happens? Every 3 to 4 hourly, patient rectum gets full. So patient is going to pass stool every 3 to 4 hourly. This is not the true diarrhea. This is fake diarrhea, also known as spurious diarrhea. Whenever patient is having malignancy in ampulla, patient is having painful defecation with sensation of incomplete evacuation. Why there is sensation of incomplete evacuation? Because of this mass. Mass is there, so patient thinks that still something is left. So that is known as tenesmus. These are the characteristic features of carcinoma rectum. Now, what is the investigation of choice for diagnosis of carcinoma rectum? It is rigid sigmoidoscopy. We perform rigid sigmoidoscopy plus biopsy. So we perform rigid sigmoidoscopy plus biopsy. Why? Because the length of rectum is 14 centimeter, length of anal canal, surgical anal canal, it is 3 centimeter, rectum it is 14 centimeter, length of rigid sigmoidoscope, that is 25 centimeter, which is sufficient to assess the rectum completely. But what happens? We have to rule out synchronous lesions, synchronous polyp or malignancy. So to rule out synchronous polyp or malignancy, we perform colonoscopy. So what is the role of colonoscopy? Colonoscopy is done to rule out synchronous polyp or malignancy. So it is done to rule out synchronous polyp or malignancy. synchronous polyp or malignancy. Now, investigation of choice for T staging. T staging, where the staging is dependent on depth of penetration. So we perform what? Transrectal ultrasound. So in carcinoma rectum, investigation of choice for T staging, it is TRUS. What is the big problem with TRUS? Transrectal ultrasound, it cannot differentiate distantly lying blood vessel from lymph node, from nerves. So that's why for lymph node staging and for overall staging, investigation of choice is MRI. And exactly what's the name? This is echo MRI, full form endorectal coil MRI. So what is the name? Name of investigation is echo MRI, also known as endorectal coil MRI. So you have to read the question carefully. Investigation of choice for T staging, TRUS. For lymph node staging and for overall staging, this is echo MRI or MRI. Now see the treatment principle. Rectum is located in the pelvis, mainly in the pelvis. So malignancy is also located in the pelvis. Pelvis is very little space and it's complex, it's having complex anatomy with important nerves and vessels. So in majority of cases of carcinoma rectum, whenever malignancy is advanced, we try to downstage it. And how we are going to downstage it? By neoadjuvant chemoradiation. So after neoadjuvant chemoradiation, the malignancy will be downstaged, and after that we perform the surgical excision. Surgical resection is the treatment for stage 1. In rest other stages, we have to give neoadjuvant chemoradiation. So for stage 1, we go for surgical resection. For stage 1, surgical resection. For stage 2 and 3, we go for neoadjuvant chemoradiation. Neoadjuvant chemoradiation. Tumor is downstaged, followed by surgical resection. Followed by surgical resection. And for stage 4 also, we go for what? Neoadjuvant chemoradiation. Clear? After neoadjuvant chemoradiation, if it's possible, we can go for surgical excision. If it's not possible, we can go for palliation, followed by surgical resection if possible. And if surgical resection it's not possible, we go for what? Palliation. We go for what? Palliation. So this is how we manage the patients of carcinoma rectum. Now see the carcinoma anal canal. Anal canal, it's located outside GIT. Anal canal, it is lined by squamous epithelium. Since it is located outside the GIT, some of the principles will be different. Since the lining is squamous epithelium, so what is the most common histological type? Squamous cell carcinoma, followed by basal cell carcinoma, followed by malignant melanoma. Here, most common site of metastasis will be lungs because it is drained into systemic circulation. So most common site of metastasis, it is lungs. It will behave like perineal malignancy, like in carcinoma penis, carcinoma scrotum, carcinoma anal canal. In all these cases, lymphatic drainage goes to inguinal lymph node. Here, most commonly involved lymph node will be inguinal. Another important point, since it's a perineal malignancy, so here human papilloma virus will be a risk factor. It is more common in low socioeconomic status. So the risk factors are smoking, human papillomavirus infection, immunocompromised state means if the patient is having HIV, patient is HIV positive, a patient is a transplant recipient receiving immunosuppressive agents. Clear? In these cases, there is increased risk. It is more common in homosexuals, especially in the passive partner. So, anal receptive intercourse, multiple partners, history of carcinoma cervix, vulval cancer. Why? Because multiple partners, history of carcinoma cervix, all of these suggest the infection. Indirectly, it gives hint with the infection of human papillomavirus. Now see this image. This is the patient. This is the anal canal, and here is the malignancy. Initially, the malignancy is located inside the anal canal. So this patient is having bleeding PR. That's the most common symptom. After some time, malignancy will come out. When malignancy will come out, the patient will be having foul smelling discharge also. So the most common symptom, it is bleeding PR. Apart from bleeding PR, patient started having foul smelling discharge. Most commonly inward lymph node, we discussed, it's inguinal. Inguinal. And what is the most common site of metastasis? That is lungs. Here, how you make the diagnosis? So obviously, investigation of choice for diagnosis, that is proctoscopy with biopsy. So here, investigation of choice for diagnosis. We go for what? Proctoscopy plus biopsy. That is proctoscopy plus biopsy. And what is the treatment of choice for carcinoma anal canal? You must be knowing. It's easy question asked frequently. This is Nigro regimen. Treatment of choice, that is Nigro regimen. So what we give in Nigro regimen, actually it's chemoradiation. So in Nigro regimen, what is given? Chemoradiation. Chemoradiation means first we give chemotherapy followed by radiation. So which agent is given in chemotherapy? In chemotherapy we give 5-fluorouracil plus mitomycin C. This is 5-fluorouracil plus mitomycin C, followed by we give radiation. So it is chemoradiation. And you can't believe tumor disappears. Tumor is so responsive that tumor disappears. So if we go for a check biopsy after 6 weeks and what? Tumor disappears, nothing should be done. But in some of the patients, if there is no improvement, means you perform the check biopsy and there is no response. So even after Nigro regimen, if there is no response, so what is the alternative treatment? We go for APR. What is the full form of APR? We perform abdominoperineal resection. So this is how we manage the patients of carcinoma anal canal, and this is all about rectum and anal canal. Now we're going to start spleen. First, see the indications of splenectomy. So you know that what is the most common indication of splenectomy? That is trauma. And the most common indication of elective splenectomy, that is ITP. The most common indication of splenectomy is trauma. This is trauma. And most common indication of elective splenectomy, that is ITP. Previously, ITP was known as immune thrombocytopenic purpura. Nowadays, the new name is immune thrombocytopenia. Short form is same, but the name has been changed. It is immune thrombocytopenia. There are certain situations in which splenectomy is always indicated, and there are certain situations in which splenectomy is usually indicated. So splenectomy is always indicated if patient is having primary splenic tumor. And you know, in hereditary spherocytosis, the treatment of choice is splenectomy. So there are two conditions where it is always indicated: primary splenic tumor, and second is hereditary spherocytosis. Another situation you can see, it is usually indicated in primary hypersplenism, patient who are having chronic ITP. And you know that if a patient is having splenic vein thrombosis, it leads to gastric varices. So patients who are having splenic vein thrombosis, it leads to gastric varices. In that case also, the treatment of choice is splenectomy. And if patient is having splenic abscess, there also it is usually indicated. So these are the indications of splenectomy. It's very easy to understand the complication. If you see the relation of spleen, it is in close relation with dome of diaphragm, left dome of diaphragm. So whenever you perform splenectomy, what happens? Because of some kind of trauma, because of injury to some fibers of diaphragm, what happens? The most common complication, that is atelectasis, means collapse of ipsilateral lung. These patients might be having pleural effusion, sometimes consolidation. Second, you can see there is a relation of pancreas with spleen. Here you can see this is the spleen. So it is in relation to which part of pancreas? Tail of pancreas. So whenever you are performing splenectomy, there is injury to tail of pancreas. There can be pancreatitis or pancreatic fistula. Another important point, after that, there might be collection of blood just below diaphragm. So that is subdiaphragmatic hematoma. And if it is infected, it leads to subdiaphragmatic abscess. The complications of splenectomy. First, what are the lung-related complications? We discussed most common complication overall, that is atelectasis. What happens? Atelectasis causes fever up to 48 hours, and this is non-infectious cause of fever. Apart from that, it can lead to consolidation. It can cause reactive pleural effusion. Now, diaphragm-related complications, there can be collection of blood, subdiaphragmatic hematoma, and whenever it is infected, it leads to subdiaphragmatic abscess. Now, pancreas-related complications, acute pancreatitis, injury to tail of pancreas, and whenever this duct is injured, because of injury of duct, some of the patients are having pancreatic fistula. You know that spleen is the storage site of blood as well as the platelets. So whenever we perform splenectomy, there is increased platelet count in the postoperative period. And because of surgery, patient is immobilized. So because of thrombocytosis and immobilization, there is increased risk of DVT. And because of this DVT, it can lead to, because of this DVT, there can be pulmonary embolism. So what happens? There can be thromboembolic complications because of thrombocytosis and immobilization. The most important topic, that is OPSI, which is frequently asked in exam. OPSI, what is the full form? This is also known as OPSI full form, overwhelming post-splenectomy infection. It is not opportunistic. This is overwhelming post-splenectomy infection. So see, this is the most common, what you have to remember, late and fatal complication. Most common late and fatal complication of splenectomy. It is seen after how many years? It is seen after 2 to 5 years. It is seen after 2 to 5 years of splenectomy. Okay, in which case there is maximum risk of splenectomy in thalassemia major followed by sickle cell anemia, and minimum risk or least risk it is seen in patients of trauma. So there is maximum risk in which patients who are having hematological disorders like thalassemia major, maximum risk in patients who are having thalassemia major followed by sickle cell anemia, sickle cell anemia, and there is least risk in which patients of trauma. Okay, we discussed that this is most common late and fatal complication. So how much is the mortality rate? It's very, very high. Mortality rate, it is 40 to 50%. So how much is the mortality rate in OPSI? That is 40 to 50%. You know, what is the function of spleen? It helps in phagocytosis of capsulated organisms. So if we are going to perform splenectomy, there is increased risk of infection caused by capsulated organisms like Pneumococcus, Strep pneumoniae, Meningococcus, Neisseria meningitidis, and the third is Haemophilus influenza type B. So organisms responsible for OPSI, most common, Strep pneumoniae, also known as Pneumococcus, Neisseria meningitidis is another organ, and Haemophilus influenza type B. These are the organs which are mainly responsible for OPSI. It is difficult to treat OPSI because how much is the mortality? 40 to 50%. But it's easy to prevent OPSI, and how we can prevent? We can prevent it by vaccination or immunization. So what is the best time to give vaccine? The best time to give vaccine is at least 2 weeks before elective splenectomy. At least 2 weeks before elective splenectomy. And whenever we are planning emergency splenectomy, here you can give it 14 days after splenectomy or upon discharge, whichever comes first. So emergency splenectomy, in emergency splenectomy, the best time to give vaccine is 14 days after splenectomy or upon discharge, whichever comes first. Now see the important questions related to splenic cyst. What is the most common true cyst of spleen? This is hydatid cyst. True means it is lined by epithelium. So this is hydatid cyst. What is the most common non-parasitic cyst? You know that hydatid cyst, it is caused by Echinococcus granulosus. It's a parasite. So most common non-parasitic cyst, it is pseudocyst. So it is not a true cyst. It's false cyst. Pseudocyst. So how pseudocyst is formed in the spleen? After trauma, there is hematoma, and this hematoma is lined by granulation tissue. So this is pseudocyst. And what is the most common? Congenital splenic cyst. Most common congenital splenic cyst, that is epidermoid. Most common congenital splenic cyst, that is epidermoid cyst. If you see the incidence, how much is the incidence of hydatid cyst? 10%. Incidence is 10%, and pseudocyst, the incidence is 70 to 80%. So if a question is asked that overall, which one is most common? Overall, most common is pseudocyst. So overall, most common is pseudocyst. But if true word is mentioned, what you have to mark? Hydatid cyst. Now see the splenic tumors. What is the most common neoplasm of spleen? That is lymphoma. And which lymphoma? This is non-Hodgkin's lymphoma. What is the most common primary benign tumor of spleen? You know, spleen is the blood bank of body. So what is the most common primary and benign tumor of spleen? It is hemangioma. This is hemangioma. And make hemangioma malignant. So if you are going to make it malignant, it becomes angiosarcoma. So what is the most common primary malignant tumor of spleen? This is angiosarcoma, also known as hemangiosarcoma. So this is angiosarcoma, also known as hemangiosarcoma. Okay. Now coming to the metastasis. What is the most common primary for splenic metastasis? It is malignant melanoma. Most common primary for Splenic metastasis, that is malignant melanoma. Malignant melanoma. But what is the problem? In melanoma, multiple organs can be affected. There is involvement of liver, involvement of spleen, involvement of mesentery. So another important point, most common primary for isolated secondaries. Isolated means only coming to the spleen, and this is carcinoma ovary. That is carcinoma ovary. So this is all about important points of spleen.